Well, hello again, and welcome to the Medical Mastery Podcast, the podcast of the Emerald Coast Medical Association. I am your amaranthine host, Don Davis, and it's always good to see you here. Thank you for being here. And I am especially pleased to welcome somebody that I like quite a bit. Her name is Lindsey Marie Weintritt Davis, and I am very happy to have her here today. So, Dr. Davis, you are a breast radiologist, you are a mother, you are a full-time, do-everything kind of person, and we're going to hear about all of that. So welcome here today.
Well, thank you for having me. I'm honored to be invited.
Are you?
Yeah.
Okay, well, we're going to test that theory here in just a little bit, okay? So I am very happy to have her here and have her start to answer some questions that have been really bothering me for a long time. So we're going to take an in-depth interview here. Start out by telling me where you're from.
So I'm from Panama City.
I've heard of it.
Born and raised.
Okay.
I'm a graduate of Mosley High School and a smoke-free class of 2000.
Yes. Were they all smoke-free? Ish. Okay.
Most.
Some.
Yeah.
Okay.
Yeah, so I grew up here. I have 3 siblings.
So you've grown up here, you've lived in Florida for most of your life. Now, you decided to go where for undergrad?
So I did undergrad at UF,
Yeah.
and then I did medical school at UF, and also radiology at the University of Florida. So I lived there quite a while.
Yeah, so you're a lifer of University of Florida. Let's take a step back here for a second. So you're going to undergrad at University of Florida. I hate to admit that it's an excellent school, but still it is. What did you want to do when you were going there?
I went to UF thinking medicine.
Yeah.
In high school, I had the opportunity to do some volunteering, and I thought I knew that I wanted to do healthcare of some kind. And so we had a unique opportunity at Mosley they called it internship, but you basically got a free period throughout the year to shadow or volunteer in some capacity.
Now, were you thinking you were just going to be taking this time off to go smoke, or like was...
No, I was the nerd. I was all in for the opportunities.
Should have known. Okay.
Yeah, so I did PT for a few weeks or months, and then I did the NICU and kind of shadowed the nurses. So I kind of got to see a variety of healthcare settings, and then I did a whole semester. Dr. Michael McCormick, who was an excellent orthopedic surgeon who's sadly recently passed away.
Yes.
He let me shadow him 2 days a week for an entire semester, one day in the clinic and one day in the OR. Why he let me do that, I have no idea, because being where I am now,
I think I know why, but either way.
It's a lot.
Yeah.
But he was great. And I think that really kind of navigated me more towards the physician side of things, because I just had a great experience shadowing him. So I went to UF thinking I was going to do med school, lots and lots of people do.
And successfully, might I add.
Turns out.
Do you want to hear a fun fact really quick?
Yes.
I live in Dr. McCormick's house.
So do I. I know. He wrote me a letter of recommendation for medical school, which
That's crazy.
It's crazy. And now we live in his house,
which is great. But it's also a nice kind of feel and verve and motion in life to kind of see those things that this person that was kind of formative somewhat in your early career that end up resulting living in that kind of environment that he had grown up in. I think it's really great.
It's very full circle.
It's very full circle indeed. So you're at University of Florida. You think that you want to go into medicine at the time. What was your degree in?
So I started out as a chemistry major, and then
Real chemistry nerd? Is that?
I liked chemistry. I liked math. I don't think I really ever thought about majoring in math. I know some people do that.
Nerds.
I thought chemistry, and part of that was because I thought, well, if medicine doesn't work out, maybe I'll do some kind of engineering, chemical engineering, something still along the, that could be related to the medical field. And along the way, I actually knew of, because my brother had done the same program, but started pursuing the junior honors medical program, which is a combined degree program that UF offers, where you start applying for medical school at the beginning of your sophomore year. There's a series of applications, and so I kind of went along, and it kept progressing to the interview process in the spring of my sophomore year, where I was accepted to that program. So in that, your junior year is still undergrad, and you do some seminars and then finish up any med school prerequisites, but you do not have to take the MCAT, which was a huge perk. And you start med school 1 year early. So your first year of medical school is actually dual enrolled with undergrad.
So how many people, this junior honors program, is it 1,500, 2,000 people that get into this per year?
It's huge.
Yeah, it's huge.
It's 12.
12 people. So that's pretty impressive. It's a very small group, and that's going to eventually get into your med school class, which is 150 or so, give or take. Yeah. So you decided relatively early. Now, I took a slightly different undergraduate career where I crammed 4 years into 5, and so I'm always interested to hear those that did a little bit less.
Yeah.
So,
I didn't do it to shorten undergrad, but I think I saw it as a second try to apply to medical school. I'll try this. If it doesn't work, then I can always apply through the traditional route. And the no MCAT was very attractive.
Yes. So you didn't really shop around in medical schools. University of Florida, again, excellent medical school. Don't tell them I said that. Was kind of your place. And so you're going into medicine. A lot of our time that we spent in undergrad studying and everything, there's a lot of pomp and circumstance to try and getting into medical school. There's a lot of applications. You have to really jump through a lot of hoops. You have to be incredibly resourceful. And that's what I think it really is testing, is how resourceful are you to be able to get all these different disjoint papers and tests and all the other things in order to get your application in, much less be accepted. So you're finally accepted. The hard part's over, right?
Yeah.
So tell me about going to medical school at University of Florida.
It was amazing. I mean, UF is a phenomenal med school, and I was familiar with Gainesville, so that was nice. I wasn't getting used to a new city, new town, but I loved it from the get-go, starting with anatomy. In retrospect, that's probably why I like radiology so much, because I love anatomy.
Yeah.
And just progressed through there. It went well. I really enjoyed, made some really good friends.
Yeah.
And then through med school, as you're perusing, what specialty might pique my interest, I thought surgery, I thought OBGYN, I liked procedures. I don't ever feel like any of those were perfectly clicked with my personality. And while I was on a rotation, a medicine rotation, I had a patient who went down to radiology and had a CT guided procedure. And so they're like, oh, go down there, check that out. Might be interesting. And I thought it was fascinating. This is amazing. This lady had a lung mass that they biopsied and cultured. It was, with her wide awake under CT, and they put a needle in her lung. And, as a medical student, I was just blown away that was available.
Right.
And so I thought, well, gosh, what's this radiology all about? Luckily, that was pretty early in my third year. And so I got permission to swap one of the third year rotations for radiology to try to get a taste of it, because you really don't have that opportunity generally until fourth year, when you're already, you have to be applying. So I got to do that at UF, and it was great. It was the end of the year, so there were no fourth years around. And they were impressed that there were there was myself and a good friend of mine, Teresa Caridi, who's also now a radiologist. But I think they were impressed that we were proactive, and so that helped as we went into the application process and then fourth year.
Yeah, and I think you elucidated something that's kind of important, which is that you don't really know until you've kind of gone through medical training for a little bit how much radiology is really doing. You wouldn't have thought that they're the ones doing biopsy if you know that. I mean, you think a lung mass, that's probably going to be biopsied by a pulmonologist, a lung doctor of some type.
And sometimes it is, but it's much more complicated.
It is, yes. But you wouldn't think so. In other words, I think, my retrospectoscope told me that radiologists read films. That's what they're doing all day long. And there's some truth to that. But also, there are some in-depth proceduralists that come out of radiology that are doing all kinds of things all the time. And so I don't know that the lay public knows that enough, that many times if you're getting a biopsy, if you're getting some fluid drained, if you're getting something placed.
We did. I mean, and there weren't a lot of fellows during our residency program. There were some in certain sections, but in the procedural-based specialties, there weren't fellows. So we got to do a ton. I got to do all kind of crazy stuff, putting in pericardial drains on a child, just stuff that you're like, why are they letting me do this? But it was great. And, we got a lot of hands-on experience. So I think, I don't know if it's the same way, but residents that come out there with really strong procedural skills. and a good taste of what's there. It's UF, so they are a tertiary referral center. We got to see lots of bread and butter, and then a lot of super rare, once in a lifetime diagnoses that you get to participate in.
Red striped zebras and other things that are strange. Yeah, but let's take a step back here and go back to the medical training for a second. So you liked your rotations in general, you liked surgery, you liked medicine, OBGYN.
I didn't love medicine.
Why? Anyhow.
It's not me.
But something kind of called to you that said that maybe imaging, radiology would be worthwhile for you.
Mm-hmm. Yeah.
And I seem to recall your brother's a surgeon, so there may have been some sort of push towards that. You liked surgery whenever you did that?
I did. I don't know what it was about it that just didn't seem like it clicked. I mean, I think before I had experience to really spend time in radiology, surgery was my top consideration. I think I was because there were some other subspecialties, ENT. I was just intrigued by all of it. I mean, I think it's all fascinating, and we had a lot of really good hands-on experience during our surgery rotations. But when I got to spend time in radiology, I think it seemed like kind of the best of both worlds, at least for my personality. There's tons of opportunity to do procedures if that's your preference. There's plenty of opportunity to do none of that if that's your preference.
Yes.
And I think there's breast imaging, which kind of lands in the middle where it's a little bit of both. So it's just, I think that's what drew me to radiology was just a lot of the procedures, but also when we were shadowing third year, the fourth year residents were preparing for their oral boards. And so we got to sit in on a noon conference and they were asking them crazy. I'm like, these are the smartest people I've ever seen. Like, how do they know that? And they're just like popping off with, a neuro case, a GI case, a peds case, with these rare, weird diagnoses and nailing it. I was like, man, you got to know a lot about a lot to be a radiologist. But it was fascinating to me. So I think that kind of pushed me that direction.
Yeah, I've seen a radiologist studying for her oral boards, and it was quite impressive. It was really oof.
Yeah, I mean, you spent a whole year preparing.
So you go into radiology residency. You do it at University of Florida. Obviously, you had impressed them enough there, and that they wanted to keep you around.
I was lucky to get in there.
I wouldn't say that. Either way, so you do an intern year. Now, you typically have a choice of how you want to do your intern year. You can do it internal medicine or surgery. Which one do you choose?
Medicine.
And why is that? I thought you didn't like medicine. What happened here?
I think after seeing the life of the surgery residents, I mean, the surgery part was fascinating to me, but the life of the surgery residents was less appealing than that of the medicine residents. And I think I thought, if I only get to do it for 1 year, I'm going to take the lesser of two evils, honestly.
You're nothing if not pragmatic. I like that.
It's pretty rare for people to do a surgical prelim year. Some people do, but it's an interesting choice.
There's an old joke about what's the worst part about being a slave? The hours, and that's the same thing with the surgery internship.
Surgical internship, or especially the first year, is
just
hazing.
Less than dirt. Yeah, it's full on hazing, and they at least take to it. But either way, so you decided to go internal medicine. Did you like internal medicine at all?
I did. I mean, there were parts of it that intrigued me. We did mostly inpatient work, so there was an acuity of care that. Kind of intrigued me. And then you also got to see, I think it's important to understand how the other side of medicine works, even though that's not what we're doing every day, but like, what are the questions these clinicians are asking? What problems can you solve for them? And then you see how the radiologist interacts and when they're helpful and when they're not. So I think there's value. There's a reason that they, have you do that prelim year. So you've got some perspective.
That's right. Yeah. And I think, the lay person wouldn't necessarily know this, that radiologists are the physician's physician. They're the ones that really help most doctors out of difficult situations. Many patients aren't going to know their radiologist. They're not going to know if the radiologist took a look at him. But many physicians will certainly know the radiologist because they'll sit down, whether that be internal medicine or surgery or otherwise, and say, or neurology that will say like, hey, help me out here. And they usually can help us out in those situations.
Yeah, and I think most radiologists love that part, especially when you get to have, interaction with other physicians and here's my clinical scenario, here's what we've tried, what do we do next? What kind of imaging should we do? Or, they've had their imaging, here's the clinical setup, what do you think? that doesn't happen as much, in private practice, just because we're all busy and we're all scattered all over the place. But
you're churning.
But it's still, valuable whenever we have the opportunity to do that. But I liked that aspect of it too, that you're having, interaction with patients some, but you're mostly interacting with other clinicians and kind of just serving as their, detective, part of their team, but just in a different way.
Yeah, and I'll take this brief sojourn to say something that my wife talks about a lot, which I really appreciate, which is that the better the clinical question that you would have for your radiologist, the better the answer that you're going to get, and that just goes for any consultation in general. The more precise that you ask your clinical question, the better outcome that's going to come from that.
Oh, absolutely.
When you say badness in belly, that's a little bit different than saying, does this patient have acute appendicitis?
Right. Yeah, it's a little harder to focus your attention to if you don't know what you're looking for. I mean, if you say, does this patient have appendicitis? I can tell you yes or no. And if it's questionable, then that clinical scenario is very helpful, right? Like,
oh yeah,
do they have, this appendix looks a little funny, but there's a kid who's up in the ER eating ice cream, running around, like they don't have appendicitis, so
yeah, that's right.
The imaging is not always cut and dry, so the clinical, as much clinical information, lab values, can help. And that's also where, having done a medicine year can help you.
Yeah.
So you've seen it on both sides. It's sort of a typical presentation of things, and then now you're seeing the imaging.
Yeah, I seem to recall a radiology saying from University of Florida, which was that don't interpret a study without a clinical scenario or you'll get sucked in or something along those lines.
Yeah.
Basically, like
garbage in, garbage out is
yeah.
really what was the colloquial saying, because it's just, it's very difficult when you have no information.
Mm-hmm. The clinical scenario matters. If it's a 10-year-old that's in front of me having chest pain versus an 85-year-old who's had bypass multiple times that is having chest pain, I'm going to interpret that entirely differently.
Sure.
My pretest probability is
Right.
going to change that a lot, and it should.
You're going to hone in on some different subtleties. I mean, obviously you look at the whole exam, but
sure. Well, and that's, I think for many of the clinicians that go and look at their own studies or review radiology films, it's very helpful when you have the radiologist that has circled the suspicious lesion or the radiology sign, that's very helpful to say, like, radiologist called this a saddle pulmonary embolus, and you look back and say, yeah, it is a pulmonary embolus. That's easy. Now, when you also have to be looking at the upper diaphragm and the small parts of the small valve that actually were on the film and other things, and I think my wife has talked about anecdotes before of getting a CT of the abdomen and pelvis and noticing this significant pulmonary embolus that's in there. That's something that you guys can't miss.
Yeah, that's, the adage in residency was you have to look at all four corners of the film, which we weren't doing film anymore, but that was, you have to look at everything. And, obviously you focus in on the main area, but then you have to, generally run back through everything. Okay, what are all the things that I didn't look at that were not germane to the study, but are still important? Because you find a lot of incidentalomas or, unexpected pathology in patients, like you said, a pulmonary embolism. They think they've got right upper quadrant pain. It's really, diaphragm pain from the pulmonary embolism. So
yes, when you're looking for a GI bleed, and yes, you caught previously healing rib fracture. It may seem of academic interest, but you didn't miss that. You were looking, I've got to look at the bone windows first. I've got to look at the soft tissue and other stuff. Yeah. Now, let's talk about how you got there, because you passed your intern year. Did you enjoy your intern year, by the way?
I loved it.
Okay, good. And then moving on from there, so you start as a second-year radiology resident. Tell me what that's like, because now for the first time you're actually doing this thing. You think, oh, I like radiology. I understand this, whatever. You don't really know anything until you've actually gone into it and you start the trial by fire.
Absolutely nothing. Your first year, you're mostly observing. You're interpreting studies, but not very many. So they give you an assignment of like, okay, you're doing plain films. We did a lot of plain films because it's the fundamentals of radiology. And then we rotated through all the different sections. We did a fair amount of peds our first year, so you got to do a lot of fluoroscopy, which was interesting. So interacting with the patients, not necessarily an invasive procedure, but interaction.
These are not little adults. They're not. Yes.
Procedure. Fluoro on NICU babies. Up to teenagers. And as the year progresses, you obviously get a little bit more responsibility. You get a little more comfortable. You have some vocabulary and idea of what you're doing, and you obtain a little bit more responsibility along the way. And then we start second year, they let you loose to take independent call. So it was kind of amazing how much you learned in that first year.
So let me get this straight. You're taking independent call overnight?
Overnight call, solo, covering all of Shands and the VA.
For a level 1 trauma center? That's you.
Yeah, at the time, yeah. It's nuts. I mean, the fact that was, I mean, I guess it went okay because that was, that was the tradition.
Still here, yeah.
But
that seems crazy and overwhelming. I mean, sure, you're going to learn a lot, but...
Yeah, I mean, it was overwhelming, but I think that setup is, I mean, you learn fast. And you learn, I think, more than anything, confidence, because there's no one to back you up. There's no one to ask, like, what do you think about this? What do you think? You got to decide. And that was one thing that was inculcated us a lot at the University of Florida, is to be decisive as a radiologist. And so that's kind of one of my founding radiology principles, because that's just how they trained us, is that if you don't know, who's going to know? And so that taking independent call, when you have Larry Lautenberg standing behind you on a trauma.
Shout out Dr. Lautenberg, yes.
Waiting, do I need to take this person to the OR or not? You develop some skills by necessity that, then go on to serve you.
I can think of, not too many higher pressure situations than having an anxious trauma surgeon sharpening their scalpels saying, do we need to take this patient back or not right now? Do we need to do an X-lap? Are they bleeding? Are they going to die right now? Because you're going to be responsible and you have to make that call. Sounds like a pretty heavy burden.
Yeah.
In hindsight,
it was terrifying. But you did it, and then you realized, oh, I actually can do that.
Yeah.
What's in retrospect kind of interesting to me is that the attending trauma surgeons took your word for it.
Yeah.
Your read was what you went on.
6 months in, I mean, come on, you have to know this, right?
And, sometimes they would question, there'd be pushback. I don't agree. I don't think so, but then there's nobody else. And so that was, kind of trial by fire is where you learn, where you have to defend your case, why you think it is. And, it's a heavy responsibility as a second year resident to be deciding if somebody's going to the OR or not. I had
very heavy.
One experience with a trauma surgeon where, I called a dissection. He did not agree, did not want to take them to the OR clearly in the middle of the night.
You are a woman, so you need to keep that in mind here, okay?
We went back and forth. He wanted me to call my attending. I did. She didn't have her phone on, which was very routine for that particular attending. And the next day I asked her, I told relayed that whole story, and she's like, "No, I think you're right. I think you have to call it." Thank goodness she agreed. Yes. And I was frustrated because he obviously didn't have trust in my reading, which, like, in retrospect, of course he didn't. I was a resident. But
I wonder if I would have. Yeah.
That's one of my vivid memories from residency is Dr. Abbott, me saying, like, what do you do? Like, how do you get people to trust you? And she's like, oh, it's super easy. Just don't ever be wrong.
Don't ever be wrong.
Don't ever be wrong.
She's got a point.
And but her point was you have to earn it.
And you do. And she certainly had, because everyone worshipped what she said was sacrosanct. If Dr. Abbott said it, I had several attendings that said, oh, Pat Abbott said it?
Right.
Okay, then don't even look, whatever, it's already taken care of. Yeah.
A force in radiology.
And there's a reason that she is because she's not wrong.
She's not wrong.
Now, she also did internal medicine too.
She did. She practiced internal medicine.
Yeah, so that probably adds a caveat to her life.
That was another thing about radiology when I was deciding what to do. The fourth year residents, amongst the radiology class, there were numerous residents who had started in one specialty and transferred into radiology, ENT, general surgery, neurosurgery, lots of surgical subspecialties. But and so that was very telling to me. And I asked, well, how many residents?
Something to you, right?
How many residents switch out to another specialty? Oh, that never happens. And so you think, like, oh, this must be the place to be. It's obviously attractive. To a variety of people.
And I think they some of them had finished residencies entirely and then decided to come back in and start again as second year.
One guy in the class ahead of me who was a practicing surgeon in town and decided to switch gears and go back to radiology. And so he's a phenomenal radiologist.
Of course.
Because, he's got all this clinical experience.
Indeed.
Yeah. I can't imagine doing that, I don't remember how long he'd practiced, but having been out in practice, can you imagine going back to residency now?
No, that wouldn't be fun. Now, you did hit on something that I kind of want to highlight, just is that, we silo ourselves in our training in a lot of different ways. And so, internal medicine, we're taking care of adults. Radiology, you're covering the gamut. I mean, NICU, you're also doing, so for example, if you're going to do GI motility studies, like you're the one that's putting in the GI motility agent. If you have to put an NG tube or something along those lines.
In residency, yes.
Yeah, in residency, I'm sorry, let's be clear. But like central lines, procedures, all those things, that was radiology that's doing it on newborns all the way up to decrepit patients.
Particularly with the fluoroscopy, barium enemas, VCUGs, where you're catheterizing a NICU baby to look for reflux.
I could imagine very little more traumatic than catheterizing a newborn baby and trying to do VC.
Newborns actually were okay. It was the toddler, older kids who
with their parents
were really not into it.
Man.
Yeah,
well,
it was hard.
Of course,
but yeah, so you got
when you really got to hit the doctors that are ordering that and saying you got to do that anyhow.
Yeah, let's traumatize this child.
And the radiology resident. So you're moving on from there. That second year, so you're moving upwards through radiology. You're continuing to get more training, continuing to get more confidence. Where did the cutoff point come where you thought maybe I want to do something as a subspecialist inside of radiology as opposed to being a general radiologist?
Yeah, so it was interesting. A lot of that is determined by kind of the current trends. What do you need to go be competitive in the job market? When I started, the graduating seniors, some of them did a fellowship, mostly the ones who wanted to go into academics, but it wasn't necessary. If you were just going to go out into a private practice setting. I started residency in 2007. So then after 2008, the job market tightened up a lot because all of a sudden radiologists couldn't retire because their 401ks were in the toilet.
No.
And so the job market was really tight. So you really kind of needed to do something to set yourself apart. And I was really on the fence about doing a fellowship because what I loved about radiology was the breadth. The variety that you get. You never know, next case, and it's always going to be different. And so I didn't love the idea of, narrowing my focus so significantly. So I kind of considered, I was getting a lot of advice from my program director.
Some of it solicited.
Rightfully so. You have to do a fellowship. You have to. You're not going to get a job. At the time, I was dating this guy who lived in Louisiana. It was long distance.
Sounds
so
awesome.
I was not excited about doing more of that. I wanted to just go get my job and move to where he was. And so I took the good advice, and decided to choose a specialty. I considered what I really liked was body imaging, GI, GU, and I think that's just because we had such a dynamic experience during our training. But I felt like I had really good body training, and I didn't, if I was doing it to be strategic in the market, that doesn't really set you apart. Not a lot of, community practices separate their imaging where you're reading the GI and GU studies. And so the other consideration I had was breast because I really liked that. You got to do some procedures. You got to interact with patients. There was still enough variety. So that's what I did. I applied. I applied kind of late because I was really being stubborn about the whole thing. So by the time I applied, a lot of people, there are matches for some of the radiology fellowships that are ACGME accredited, similar to the residency match, but that's really only neuro and IR. The rest of them, it's kind of just a job interview and it's a rolling application process and they try to fill their spots really early. So it was sometime in the fall, maybe Christmas time, when I acquiesced to do a fellowship and reached out to a ton of programs. And there were actually 2 in DC that had unfilled spots, George Washington and GW, or George Washington and Georgetown.
And Georgetown, yeah.
So I arranged an interview on the same day, went to one in the morning and one in the afternoon. And luckily they both seemed great. The the Georgetown fellowship was more of a women's imaging. So you did half the year breast and half the year pelvic MRI. And the GW fellowship was all breast. And, some thought amongst, more senior radiologists was like, you don't need a whole year of breast. It's not that complicated. But I just liked the environment at the GW fellowship much better. So I reluctantly went and did that, and it's the best thing I've ever done. I mean, obviously, and the guy turned out okay because he's not my husband, so he stuck around for another year of long distance.
Well, I'm looking forward to hear about him. So you go to GW for a year. Now, this is the first time that you've been away from University of Florida for a decade plus. Yeah, or out of Florida ever. So, what was it like moving to Washington D.C.?
I mean, it was great. It was very different. I didn't take a car. I was living the big city life. I got an apartment that was just a couple blocks from the hospital. And so I just walked everywhere and took the metro, which is a total novelty to someone who's lived in
a big city,
medium-sized Florida city for a while. So it was great. And our fellowship was incredible. There were 3 fellows and 3 attendings. So you got basically one-on-one.
Sounds like a pretty big fellowship for breast imaging. Is that right?
It was a super busy department. But you got, a lot of focused, instruction, but also feedback. I mean, you spend a whole week doing nothing but procedures, and you do, 10 or 15 procedures a day. And then the next week you'd be doing diagnostics, and you're sitting with the attending, like just doing diagnostics. And because it was a 1-to-1 ratio, we just got constant feedback from them, until a point when they kind of let us fly on our own a little bit. But it was great. It was when I interviewed one of the attendings, Jessica Trente, who's still a good friend.
Trente. Yes.
She was like, if you come here, you'll go out being able to run a breast center from day one. She was right.
She was indeed. And she's a quite accomplished breast radiologist herself. So you go here, you're spending a year doing this. Now, I happen to know, just because my wife works in this field, breast radiology tends to be more of a clinical pursuit. You're face-to-face with patients. You're actually interacting with them. That doesn't seem to be typical of radiologists.
No. And at GW, for every diagnostic mammogram is patient presents with a problem. They feel a lump, or they had an abnormal mammogram, so they're there for a problem-solving type exam. And we brought every single patient into the reading room to review their films and go over their results and our recommendations. So, it was, and if you weren't doing that, you were doing procedures. And so, it was constant patient interaction.
So you're not wearing scrubs anymore, like you actually.
Oh, you never wear scrubs in breast imaging. They're,
what are you doing with your career?
Same in residency. It was like, I wore scrubs every day for 5 years, except for the months you were on breast. And it wasn't fancy, but it was just well accepted that scrubs were not appropriate for breast. And it was honestly years into my practice here when I realized I can wear scrubs. So now it's my uniform again.
But it is, perhaps a little bit different radiology field. Many radiologists don't like breast radiology. Is that fair to say? They kind of just leave it for the breast radiologist to take care of, as opposed to, many MSK radiologists or neuroradiologists can still read body and can do all that kind of stuff.
Right. It's you either love it or you hate it. Which also makes it, an advantageous fellowship or subspecialty because, groups are constantly in need, and it's not something that a lot of times the rest of the members of the group can just pitch in and help. So you're very valuable in a practice that does any significant amount of breast, because they're like, just let them do it, and then we'll focus on the other stuff. And it's kind of a nice divide and conquer.
I think you're valuable. Now, did you find that you loved it?
I did. It was hard for me because I loved it, but I also loved the rest of radiology. So I missed doing general radiology during that year. We did, because you're really kind of an attending, an underpaid attending during your fellowship. Right? So you're eligible to, read plain films. They really didn't have moonlighting opportunities within GW, but you were assigned to read out the residents plain films, every couple of weekends. And so you'd sit with them in the morning and go over all the films that they had read and check it, and, made sure you agreed, change their reports, whatever you needed to do. Same way, the attendings did in the other section. So I got to do some of that plain film, but, I did miss the cross-sectional imaging and just the kind of breadth of pathophysiology and the rest of radiology. So when I was looking for a job, a lot of people come out of a breast fellowship and just go and they only do breast, they only practice that. And I didn't want to do that. One, because I just, I missed doing the rest of radiology, and I just really enjoyed the variety, outpatient, inpatient, emergency, cancer follow-ups. And so I was looking for a job that was, a little bit of everything.
So I want to get there, but I do want to just double click on the concept of, it's such a weird position when you go into fellowship, because you were board certified radiologist at that point. I was board certified internal medicine doctor going into cardiology fellowship, and so in some sense you're a real deal doctor.
Oh, yeah.
You're board certified, you can be paid, you're legitimate, you can do this thing, and you don't know about this other thing that you're supposed to be. So it's like
they go and find something that you still are inadequate at.
Absolutely, and woefully inadequate. Not just a little bit, like I can hem and haw about this. No, it's I say I went into cardiology fellowship and didn't know the first thing about cardiology when I got in there. And so
it's very humbling.
You have to learn. It's very humbling,
which is beneficial, I think.
It's good because being humble throughout your career will probably end up getting you better outcomes at the end of the day.
Absolutely.
So you finish fellowship. It's a 1-year fellowship. Is that right? Okay. And so then where'd you go from there?
Well, again, there was still this guy who was still in Louisiana.
Just dragging you down.
Who
Good
I
Lord.
was very determined we were not going to continue to do long distance. And so, but this was
He might have been determined too, but
2012. Anyway. I know he just wasn't mobile at that point. He still had 1 more year of fellowship. So it was 2012, and the job market was super tight. I mean, there were just no jobs, and especially in the greater New Orleans area, which is where I was looking. I mean, I was cold calling practices, trying to find a job around that area, and there was nothing. And again, I was being stubborn. I don't know if it's a theme. I was like, well, I'll just do locums, or I'll do.
First time hearing of it.
I just was very determined to not continue to do long distance. And so again, I was late to the party. I didn't have a job, by Christmas time, which was appalling to my fellowship director, who sends her fellows out to these very prestigious, either academic centers or big breast centers. And the thought of me being unemployed at the end of my fellowship was not acceptable to her. By chance, it's a very Panama City story, but my dad ran into Chris Reese, whose husband, Dr. Reese, is...
Shout out George Reese. Yes.
Was a busy breast surgeon in town. And, they're chatting, what are your kids up to? They had a kid in medical school. Lindsey's finishing a breast imaging fellowship. And she was like, what? Bay Radiology is looking for a breast imager, like right now. So my dad called and he was like, I got you a job interview. I was like, what? And I was like, no, Dad, I'm not coming to Panama City. Nothing against Panama City, but it wasn't New Orleans or anywhere close. And he was like, just go to the interview. Like, you get a free trip home. It'll be fine. So I came for the interview reluctantly.
Had no desire to come to Panama City.
No, and not because there was anything wrong with Panama City. I think it just didn't occur to me as a place that would have a lot of opportunities, especially for a quasi subspecialty trained or job focused like that. So I really came to the interview thinking like I'm just checking a box. I also told them, well, I have this guy in New Orleans.
Just
who,
like,
in a year he's going to finish, and like I don't want to sign on somewhere, and then if we have, if he can't get a job here, we might have to move. And so they arranged for him/you to have a couple interviews while we were here. So we both kind of met different groups and interviewed, and by the end of the weekend, I was like, oh, it's perfect.
I hate how awesome this is going to be.
There's a series of me being stubborn, plans not going at all how I thought they would, and it turning out to be the best thing that ever happened.
We're going to have to cut this. So anyhow, all right. So you again, perhaps semi-reluctantly at first, but then eventually take the job here in Panama City.
I did. And I mean, it was and is still an amazing job. You know, I joined Bay Radiology in 2013. And at that time, there's a lot of diversity in the practice. It was physician owned and operated and still is. But, you know, we covered the hospitals, we covered a lot of outpatient imaging. They owned an interventional outpatient office and a women's imaging center that did a variety of imaging studies, but with a focus on breast. Mammography was the bulk of their volume. And so when I took that job, I was replacing Dr. Strominger, who was a stalwart member of that group and did a lot of breast imaging. So they needed, you know, his breast imaging role filled.
Anybody that didn't like Dr. Strominger?
No, he's amazing. Talk about gigantic shoes to fill. You know, he's been there for years and years and years, and here's this new girl, especially, you know, even for the staff to come behind him, who is like the ECG that doesn't blip. I've never seen him upset. Like nothing's ever a problem.
Right.
You know, so to come right out of training nervous to, I was not used to that environment, and neither was the staff. But it was great. So I did about 50% breast imaging at our breast imaging center. And then the other half of the time was scattered around the other places that we covered around town.
So you were still doing some general radiology while you were doing this breast imaging?
I was. And, you know, at the time that was important to me. I really didn't want to pigeonhole myself into just breast imaging. I didn't want to give up all my skills because, I mean, you use it or lose it. And so that was important to me to continue to participate. And at the time, I mean, all of the partners took equal call. So I mean, you kind of needed to do that. They didn't have, at least at that time, a model for this just breast imager. And so it was a great fit. You know, the imaging center was, a well-oiled machine, but I mean, the staff was amazing. The technology are amazing. It was just, I couldn't have picked a better environment, a practice environment to start. So here I came.
Yeah. And so you've practiced in that same practice for now
13
years.
12 years. How long have we been married? 11 years? 1 year more than that.
Oh, that's right. We are.
Yeah,
okay. Yes.
Yeah. 12 years.
Don't quiz me on that on the podcast. Yeah. Okay.
So I continued to work at Bay Radiology, and the practice has evolved over the years. I mean, through Hurricane Michael, that shifted a lot of things for us. So, it looks very different now than it did, except for the Women's Imaging Center that is where I am. And so I, over time, now just do breast imaging, the thing I said I would never do. But it's great. I mean, I think when I made that shift, I still had the opportunity to read some cross-sectional imaging and some plain films and ultrasounds, but I was not doing so, I was doing so little of it. I didn't feel, you start to feel less comfortable. And so, the way I thought about it is, well, there are lots of able radiologists who can take care of that stuff. There aren't a lot of people lining up to do the breast imaging. And so I'll just focus there. It's where I was sort of like, that's where I was most needed.
Yeah. Yeah. And it's pretty busy there, you would say, right? Compared to say so for example, GW, the fellowship was pretty busy. I mean, you had a lot of people there. How would you compare the busyness of the two?
There, I think the volume is similar in terms of, the number of diagnostics you do in a day, the number of procedures you might do in a day. The difference is there's one person doing it and not 6 people doing it. And so, it hasn't always been that way. We've luckily been blessed with growing volume as Panama City gets larger. Our volume is growing. And, you get faster, in private practice. But it's very busy. We see a lot of women, luckily. It's a good problem to have.
And a few men as well.
We certainly do.
Yes,
we certainly do.
And so you're helping a lot of people. Now, all right. You made it to the hard part of talking about all of your life thus far. Okay, let's start to talk about radiology and breast radiology specifically. Okay, what is the difference for those of us that don't know between a screening and a diagnostic mammogram?
So the exams are generally the same. The pictures we take are the same if you're kind of starting from scratch. The difference is a screening mammogram is for women generally over 40 who have no issues, no problems. They have no reason to suspect that they have a breast cancer. We're just a screening test, same as you would do a screening colonoscopy or a pap smear or, general lab work just to check and see how things are doing. And if that's abnormal, then you'd come back for a diagnostic mammogram where we would focus in on whatever, the issue was. Also for patients who have symptoms, a palpable lump or pain or nipple discharge or skin changes, anything that is out of the ordinary for them, they'll come and have a diagnostic mammogram. And we start with those same, standard views, but then we focus in on their area of concern. And typically, we'll add an ultrasound or extra pictures to kind of make sure, same as we were saying earlier, the more history you have, the more you can focus your exam and address their specific concern. We also do diagnostics for patients who've recently, had a breast cancer, had surgery, or had a biopsy, and we're following up those changes.
Yeah. And what's the patient experience difference between the screening and the diagnostic mammogram?
The screening mammogram, you come and get your images, and then you leave, and then you get your results later from your doctor or through the portal. And with the diagnostic exam, at least at our facility, other places do it differently, but they get their results the same day. The radiologist is on site to talk with them if they need to. Now, as our volume's grown, a lot of times, if it's good news, I have a patient navigator who's excellent, and the technologist also will, kind of dispo those patients. It's all good, everything's fine, we'll see you next year. If there's, more than that, especially if a patient needs a biopsy, then I usually will sit down and talk with them about that. And so it's nice that we're on site. A lot of radiology is kind of shifting to teleradiology, and that's the big conundrum in breast. Do you do the diagnostics on site, or you're there to go in? Sometimes I'll go in and scan the patient myself behind the ultrasound tech. Every tech I have is amazing, but sometimes you got to be there, and see it for yourself, which you can't do from home. And then also, having those sit downs with patients, especially when they need a biopsy, but sometimes, they just, have concerns. They don't feel like they're, they want to make sure they're heard and that we've addressed what they need. And so I think it's very valuable. At least, I don't know that the outcomes are very different, but I think the patient experience is much better when you can sit down and a lot of them are shocked, like, oh, I didn't know a radiologist ever talked to patients.
They don't like it. No, that's not true. But there's a big difference there. The screening, you're going to take it, you're going to go home, or you're going to get the exam, you're going to go home. Diagnostic, we're going to figure out what's going on here.
You get a decision one way or another. It's either normal or you need a biopsy, or maybe we'll do a follow-up, but you get some plan and you get those results the same day.
So you're going to hang around. It's going to be a longer visit experience for you. However, it is definitely going to get down to a more diagnostic route about what we're going to do about whatever it is. So now there are other technologies we typically think of breast imaging as just mammograms. What other kind of modalities do you guys do?
So, when I trained, tomosynthesis was not widely available. So that's the 3D mammogram that now is the standard of care. But it, traditionally you just did a 2-dimensional mammogram like a chest x-ray, it's just one film. They added tomosynthesis. It kind of was in development during my residency and fellowship, but we didn't even have it at GW yet. It was kind of just hitting the market for practices to adopt. So that was a shift that, here I'm freshly trained and learning a new modality in practice when we upgraded our equipment just a few years later. Doesn't
that get you like some sense of what the old school radiologists were doing whenever they had to just learn MRI
CT.
or learn CT for the first time, and how awkward that must have been?
And a lot of clinicians are excited. They're ordering this new test and you're like, okay.
No, again, you're the expert, so who are they going to ask?
Yeah, and you go to courses and study, and there were a lot of now, these days there's tons of valuable resources on the internet. So you essentially train yourself, when new modalities come out. And so we've had several new modalities that I've added to our repertoire at the office that I didn't learn in training. MRI is a common, not common, but useful modality that we use in a variety of circumstances. So it's a specific MRI of the breast, and it's a contrasted exam. So we're looking for enhancement. And we use that either to troubleshoot or to screen patients who are high risk, or in patients who have, recently gotten a diagnosis of a breast cancer. And we want to make sure that there aren't any other sites of disease before they go have their surgery. There are no surprises.
Because that's going to change how you're going to be disposed
Absolutely.
there, whether or not you're going to maybe go towards lumpectomy versus mastectomy versus systemic chemotherapy, et cetera.
Right. And I kind of jumped ahead there. Ultrasound is probably the second most common modality we use besides mammography. And we have traditional ultrasound, where the technologist holds the wand and scans the patient. And then we also have a newer technology. We've had it for about 10 years. It's as old as Avery, 9.5. That's how I date things.
Yeah, right.
We added that to the practice, and that I had learned in fellowship. The fellows didn't get to do it a ton because it was part of a research study that they were doing there. But that, it's a great test. It's a whole breast ultrasound. It's called automated breast ultrasound is the ABUS. And so the technologist is there and they place the transducer on the patient, but it's automated. It just scans. And so then when you are reading that, it's like you're there because you get to see images of the whole breast versus a handheld. How we call the traditional ultrasound is the technologist looks and then captures images of whatever they deem significant or normal tissue, if they're trying to show you there's nothing significant. But if they don't see it, you never see it. So I like ABUS for screening. It also offers us comparison. I've got images of the entire breast. So when you have one next year, I can go back and see, was that there, or is it new? It just helps you with your clinical decision making. So that's been a useful modality we've added to our practice, and that's for patients with dense breast tissue. Patients with dense breast tissue really should have some kind of supplemental screening. Some places do ultrasound, some places do MRI. Now we've introduced contrast-enhanced mammography, which is kind of the technology is very different, but it's kind of a hybrid of a mammogram and an MRI because you give them intravenous contrast and then look for enhancement in the breast, same as you do on the MRI. The difference is it's not dynamic enhancement where you can, on an MRI, it's very detailed. You can assess for washout, that sort of how does it enhance? Does it enhance slowly?
Yeah.
And that even, offers another layer of confidence in the findings, or kind of helps you differentiate benign versus suspicious findings. So, we've got a variety of options.
Yeah. Well, so what I like about all this is that, so these are theoretically catching different things that you wouldn't catch otherwise. You're going to see certain things on ultrasound that you might not see on tomosynthesis or plain film.
Right.
Or,
have you been listening to my patient interactions for ladies who don't want a mammogram?
They're
two different tests. They show different things. We get the best results when we put them together.
I'm writing the script down. Okay.
Yeah, but that's exactly right, because they're wildly different modalities. So there are features of pathophysiology that are elucidated with X-ray or tomosynthesis, versus ultrasound that shows you different characteristics. It's more, is it cystic or is it solid? Is it a mass with margins? So, is there vascularity or blood flow to the lesion? So, we, use all that information, same as you do in the rest of radiology. You look at their plain film, you look at their CT, or you look at their CT and you look at their MRI, and the more information you have, the more you can hone in on a specific diagnosis.
Yeah, and this harkens to a larger subject, which is cancer is a bunch of different diseases. It is not just the same thing. So we say we're looking for breast cancer whenever we do screening mammograms or other sort of mammographic imaging. The truth is that we're actually looking for a lot of different types of lesions that show up. We say that they're all cancer, but they are really going to act, they're going to behave a lot differently. The treatment may be different for a lot of these different things. And so we have to utilize different modalities for those. And so that's why you have an expert that can kind of guide you on that.
Right.
So one more thing I want to talk about with the tomosynthesis is 3D mammography. So you just have the plain film, but you can actually go in depth into it, and you can see different things that can kind of come into focus.
3D like a spinning model. It's more analogous to a CAT scan, a CT, where it's computed tomography versus tomosynthesis. They're like, at least in theory, based on the same type of technology where you acquire a volume of data, and then it's processed such that you can scroll through it slice by slice. So instead of just looking through the breast from two directions, now I can scroll, and it helps because it kind of removes the tissue above and below it. So you minimize summation artifact, which was a problem on 2D mammography, where you've got overlapping tissue that sort of looks like a mass. Now you can go slice by slice and see, is that real?
So you get to see if they're more real or more not.
Yeah,
the things
it's more
that you're
specific, and it's also more sensitive because you can kind of look at every layer of the breast tissue, especially in patients with dense breasts, but in all comers, the cancer detection rate is better with tomosynthesis.
Now, breast density in women. Are they going to be able to feel their dense breasts? Can you tell that you have dense breasts, or is this just is a mammographic finding?
It's strictly a mammographic phenomenon. It's just a visual inspection.
It has nothing to do with size or shape or anything like that. You just happen to be more dense, and the density that causes problems in detecting breast cancer, or that's a risk factor in and of itself for breast cancers?
Both.
Yes, and
yes.
Okay.
So it makes the dense tissue is the white tissue, if you've ever seen a mammogram. And, we all have a varying degree of that, and so some patients' breast is comprised of mostly fatty tissue, which for the purposes of mammography is advantageous because there's not a lot of tissue, in the way, to hide a breast cancer, versus patients with very dense breast tissue. A lot of times the mammogram is just white, and so breast cancer on mammography is also white. And so the analogy we use with patients is like finding a snowball in a snowstorm. There's no density differentiation. Right? There's no contrast. No, it's not. So it makes their mammogram more difficult to read, or less sensitive. But it also is an independent risk factor for breast cancer, which I don't think a lot of patients know. It's analogous to having a family member, like a family history of breast cancer. It kind of elevates your risk to that level.
That sounds like a significant increase.
Yeah.
Now, do you have a model in your mind for why that is? Why does breast density? I mean, what is this dense tissue? Do you have any ideas of what that is?
It's not really well understood. I think the thought is that tissue more proliferative, or is there just more of it? More ductal and lobular elements. There's not like a hard and fast explanation.
Now, it would seem like you have referring physicians that send to you for screening or diagnostic mammography. Easy for me to say. And then, but you probably are working hand in hand with many surgeons. Is that accurate?
We do. Ultimately, when a breast cancer is diagnosed, the patient's first step is usually to see a breast surgeon, and they kind of quarterback at least the initial direction of their care. Are they going to have surgery first, or do they need to be referred to an oncologist? A lot of times those referrals happen so that they see everybody at the beginning, but it starts with the surgeon. And so as they're working up a patient, do we need to do additional biopsies? Were there additional suspicious findings? And when they're making their surgical plan, what is the extent of disease? Yeah. There are some features of cancers that, will push you lumpectomy versus mastectomy. There's, a whole decision tree there. And so the imaging a lot of times is what determines that, because, you don't know the true extent of the disease until you take it out. But, the imaging, in the meantime, the imaging is the best we have to offer them to sort of give them an idea of what they're dealing with.
Yeah. And then you're going to be crucial after postoperatively in many cases, because you're going to be responsible for the enhanced screening for these patients that clearly have some sort of risk factor that is pushing their body towards making these lesions.
Right. And once you've had one breast cancer, your risk is significantly higher, even in the other breast. There's just something about your breast tissue or your genetics
body
that
makes a hobby out of
makes cancer.
Making cancers.
And so for patients who have a lumpectomy, or breast conservation therapy, or conserving surgery is what that's called, then they get surveillance more frequently, at least on the cancer side in the initial period. Once they're a couple of years out, then they can go back to just once a year mammography, a lot of times with some additional supplemental screening as appropriate for their scenario with either ultrasound or MRI.
Now, there's a lot of increased genetic predisposition towards breast cancers and other cancers. Probably most famous is BRCA1 and BRCA2 genes that predispose you significantly towards higher breast cancer rates. Right. When you get that history from patients, does that make you look at things differently? Is that germane history that you think changes your clinical view on things?
Yeah, because they're at, depending on the mutation or their family history. Some patients have an incredibly strong family history with, 7 or 8 women on their mother's side who've had breast cancer, so
that's a red flag, right?
I mean, you can put those patients basically in the same category.
They don't necessarily have to have BRCA1 or BRCA2. There's something there.
Yeah. And there are risk assessment models that we also use that you can plug into, a variety of their patients' history, their menstrual history, other cancer history. Have they had biopsies? I mean, you plug in all these details into a model, and it produces their estimated lifetime risk of breast cancer. So we use that, so anybody with an estimated lifetime risk of breast cancer more than 20% is considered high risk. But the mutation carriers, certainly, I mean, their risk is upwards of 85%, just by being a mutation carrier is very high. So, we do, I mean, obviously we look at all the images, but I don't think it changes the way I look at it, but it changes my management a little more often. You're much less inclined to follow some finding that's kind of indeterminate, or intermediate, where, in somebody who's low risk, you might say, you at least give them the option. Do you prefer a 6-month follow-up, or would you prefer to just go ahead and have the biopsy? Mutation carriers, we don't really offer, the follow-up a lot of times because, you just, no stone
You're playing
unturned.
with fire at that point. Yeah.
So, I mean, the imaging, and they do get some additional screening, MRI usually, in addition to the traditional breast cancer screening more frequently. But it's really the management decisions that their history, influences.
Yeah, this is something that I think many physicians understand, but perhaps the lay public is not quite as understanding of, which is that, screening mammography, basically most of the imaging that you're going to be doing is not preventing any breast cancer at all.
No, none of it.
It's not there to prevent anything. No. So when we say that breast cancer screening saves lives, what are we really meaning there?
Yeah, it's the early detection of breast cancer via screening that saves lives. I mean, unfortunately, we don't have any modality to prevent breast cancer, or to predict who's going to have it. And so we're just playing defense, and we hope to catch breast cancers when they're very, very small and early, so that it minimizes patients, minimizes their mortality.
Yes, and morbidity.
And also minimizes their morbidity by limiting the adjunct treatments that they get in addition to surgery. So, I mean, that's the name of the game, is to find breast cancers. That's why we want women to have a mammogram once a year, because when you lengthen that interval, the longer a cancer has to grow. If we see patients once a year, it's long enough for things to have changed, but to be detectable on the mammogram, but not so long that, things have gotten to a dangerous size.
Yeah, I think there's 2 points that I want to cover there. First of all is that, a lumpectomy with radiation is going to, in general, be better tolerated and have less profound effect than systemic chemotherapy. And these are some of the things that you're looking to do. The earlier that you can catch that and just take out whatever small cancer that is, certainly before it spread to lymph nodes and other things, that's going to change your prognosis quite a bit.
Yeah, I mean, their mortality risk, is significantly higher, either the later stage or the later stage disease that you have, certainly with systemic disease. I mean, patients still can do well, but, it's a very different treatment regimen and conversation than you have 5 millimeters of DCIS. And we see both. We see a wide range. I mean, luckily, we don't typically see large metastatic breast cancers in patients who are doing annual screening. Yes. Unfortunately, usually those patients are ones who have not had a mammogram or hadn't had one in many years. And so they present with a palpable lump, sort of prompts them to get a mammogram, or they, life happens and you missed a couple of years and you come back and now there's been significant change. But usually, breast cancers detected with mammography when patients are having regular screening are smaller and earlier stage.
Yeah, and so the ductal carcinoma in situ is cancer. It's just contained, so it has not broken through a capsule or extended to different planes of texture. So it's more localized. We can remove that typically more with lumpectomy and radiation afterwards.
Right, and because if there's truly no invasive component on the surgical pathology, then they don't have the opportunity for systemic spread if it's not invaded. I mean, you still do some precautionary measures, but they don't require systemic staging, because if it hasn't invaded out of the duct, then it hasn't made it to the lymph nodes or elsewhere.
Yeah. Well, there's perhaps some controversial screening recommendations that have come from this that are every other year recommendation for women for screening mammography, as opposed to annual screening. And I think swept under the rug out of all of that is that, and even they will admit, is that more women will get cancer.
Oh, yeah. I mean, more women will die of breast cancer. I mean, when they did that analysis, it was the United States Preventative Services Task Force. I always get that tongue twister wrong, but
you did great with that, actually, yes.
They looked at, a bunch of meta-analyses, a bunch of studies looking at mortality with mammography, but they also took into account cost and, to the patient and to society. There were economists on their panel. There were no breast cancer physicians, no surgeons, no radiologists.
I want to pause on that for a second. For this screening mammography recommendation from the United States Task Force that really wants to look at all of this, there were 0 radiologists, there were 0 breast imagers, there were 0 clinicians on that task force. This is an economic advice. That is where this is coming from.
Yeah.
Okay.
So I think when you look at those recommendations, you have to look at what organization is making that recommendation and what's their motivation. If you look at the organizations of every specialty that takes care of breast cancer patients, their recommendation is once a year. The surgeons, the oncologists, the radiologists, all of them are very emphatic because they see the impact that has. And there were recommendations. I think they've retracted some of that. I just stayed steadfast with our recommendation, for annual, but then also, there were through a few different organizations, medical societies, recommendations to stop mammography, beyond age 70. Which
seems
is
like an arbitrary
crazy
and capricious line to draw. I mean, there are relatively functional and healthy 80-plus-year-olds that are out there that could get a lumpectomy and I think do fine, right?
I have patients in my screening pool who are 20 years, they're 90-something, and they're 20 years out from a breast cancer. And obviously, if you live 20 more years, that breast cancer is, that's going to be life-limiting at some point. And so you take those patients and you make that, their breast cancer wasn't their life-limiting diagnosis. And so we, and even patients, we've had patients in their 90s. We find a small, they're still screening. We find a small breast cancer and they're able to, have a simple surgery that, if their functional status is appropriate, they can have that treated and they might live another 10 years.
And they don't even necessarily have to have radiation if they don't want afterwards. They could be, but either way,
Yeah. So, I think it's still impactful. And I see every day patients who are older, 70s, 80s, who we find an early breast cancer, and none of us know how many days we have, so
true.
We try to just treat everybody so that breast cancer is a bump in their road and not the end of their road.
Yeah, and so I think what to extract from all of that is make it an annual thing, ladies. Okay, so annual mammography.
Yeah, it's also just easier to keep track of.
It's much easier.
When you start lengthening the screening intervals, you're like, did I have it last year? Did I not? That's not the motivation, but that is a benefit of annual mammography. Is like you just do it kind of the same time every year.
And there are occasionally some substrates, some patients that end up having very aggressive breast cancers over that screening period. You will catch that. So you can imagine if you extended that another 18 months, that's some sort of hormonally sensitive breast cancer, or maybe even not, that it could grow incredibly aggressively. Now, just as an aside, there's different hormonal sensitivities, estrogen, progesterone responsive, there's HER2 positivity. That is kind of a risk factor for how these cancers are both responding to the hormonal environment, milieu of the body, but also to the prognosis of how aggressive the cancer is going to be overall. Can you see a difference in lesions where you can think these are more sensitive to others? Can you tell a triple negative breast cancer?
There are some attributes of certain breast cancer subtypes that are, more classic. So the classic triple negative breast cancer, it's actually very scary because it presents a lot of times as a fairly circumscribed mass because it's growing so fast. It hasn't had the opportunity to produce that desmoplastic reaction that indolent cancers where they get spiculated margins and, fibrosis that's retracting the tissue.
We tend to think smooth is going to be more benign. That's
it typically
just rule
is,
of thumb, yes.
Unless it isn't. And so so we use different parameters to decide, what do we biopsy and what do we not, because you can't biopsy every single lesion you see in the breast, but, that's our job is to help triage different lesions and into what needs a biopsy and what needs a follow-up.
Yeah. So every single thing that you see on mammogram, you're not biopsying. It's you're biopsying the things that, hey, this is new, which is why having repeat films that you can compare with, that is gold mine for radiologists so that they can compare to the past. And then also things that are growing a little bit more rapidly than they should. That's something that catches your eye.
Yeah, really any change, and then obviously sometimes patients say they don't have prior imaging, and so you don't have that information to decide, how long has this been there, and so you kind of have to use a different decision tree. But morphology, how does it look, is a big player, but also, has it, what is the evolution over time?
Yeah, exactly. From the cardiovascular side, we always say, I don't really care how it looks, I care how it acts.
Right.
And all of these things, of course, you are for self-breast examination. Of course, that's great. However, what you're catching is going to be hopefully long before it's palpable.
Right.
The palpable stage is we're well past the point of where you're catching it at the sub 5 millimeter range.
Yeah, the idea is that, we find clinically undetectable cancers with mammography, but there are patients who have interval cancers, cancers that develop between mammograms, and a lot of times those are, can be aggressive, and so that's where the self-breast exam is important, because you might notice something different in the meantime before it's time for your next mammogram.
Keep doing those,
That's right.
but
That's right. And
also
no
get
test
screening
is perfect.
mammography.
So we come at it from all angles so that we catch as much as we can.
So tell me about, and this will be a nice dovetail for us here. Tell me about how AI is going to be integrated into your field.
There's a huge buzz about AI throughout the world, but in radiology, I think there are different schools of thought. There are some people who think AI is going to take our jobs, it's going to replace us, we're going to be unemployed in a few years, and other people who think, oh, AI can never be better than a human. And I think I fall somewhere in the middle, where
Very
I think the
circumspect place to be, by the way.
The AI that we have available now, the AI type products, are really analogous to CAD, computer-aided detection, which we've had for decades.
For a while.
Basically, soon after digital mammography was available, you could apply this computer-aided detection, which is an AI, a simple AI model where they showed it a bunch of cancers, and it detects features similar to those that, were in the biopsy-proven cancers. And that product is still available. We have that. And now there are CAD products for tomosynthesis, for ABUS, for most of the standard exams that we do.
Sure.
Interestingly, they're branding them as AI now. And they're essentially CAD.
Yeah, it's the EKG readers.
Sure. And I think where those are helpful, and where at least the early, these types of AI is, it's another set of eyes.
That's right.
It helps you not miss something subtle. It helps, I think helps level the playing field if you have radiologists in small communities where they don't have breast imagers and they're, just kind of doing a little bit of everything, but may, not have as much experience with mammography. I think it kind of elevates that,
right.
improves their accuracy. But it's not very specific.
Right. It is very sensitive and not very specific.
Right. So it marks also, vascular calcifications and calls them very suspicious, high likelihood of malignancy, when they're obviously zero likelihood of malignancy and not at all something you should biopsy.
Hopefully we would not you don't want to see the biopsy sample be like is it endothelium?
Yes, normal endothelium.
Normal endothelium is not a good biopsy result.
Not good. So we've adopted, with we've recently upgraded several modalities, equipment, our mammography machines and our ABUS machine. And so with the newer model machines are these new software products that you can add on. And we've added on essentially all of them because, my thought is, if it's something that can make me even a little bit better, a little bit more efficient, why would I not do that?
Of course.
And so I think that will continue to evolve. And I think, there's a huge shortage of radiologists now, and specifically breast radiologists. So, we may need that to evolve to help us triage patients to who needs a breast imager, a dedicated breast imager, and who, might have a simple negative study. I think those are ways that in the short term, as AI evolves to, sort of be that second reader, you can offer patients better results. And I mean, I'm all for increased efficiency, increased accuracy. I mean, no one's perfect. You're tired. Everybody has bad days. So I think having those extra layers of information, just helps everyone's accuracy.
Yeah. Now, because we are in some sense government employees, does the government remunerate you for using computer-aided detection?
They do not. There's not in the early days of CAD, there was a code. So
yes.
Practices, because it's expensive. It's a software product.
Yes.
I mean, in the old days, you had a physical CAD server. Now, it's kind of a software overlay. But they're expensive. I mean, tens of thousands of dollars to add this to your machine. And usually now everything's a subscription, so it's an ongoing cost that is not reimbursable. It's all bundled now, like a lot of things are.
This is my point entirely. Is so you're not incentivized to utilize this thing that's going to help to detect things.
Some practices charge. I've heard of that. I mean, nowhere around here, but some. I've heard that through the grapevine, that there are practices who, well, if you want AI to also read your mammogram, you can pay an extra $75. And I get it, because I mean, it is expensive, but I don't think what we have available now is true really AI enough I don't consider that something that the patient should. It's not good enough that I think that you should charge a patient for it. But I mean, it is a conundrum as a business owner to, add extra expense. It's helpful, but not reimbursable.
Yes. Perhaps the government should reimburse more.
Right. And
I'm just spitballing here. We'll see if this lands, okay?
I think that'll be interesting, because right now, I mean, whatever AI you have, it can't replace a doctor currently. You have to have a licensed physician to bill for it, to be credentialed through the payers. And so I think that will be the barrier to our jobs going away, is who's going to say it's okay for AI to interpret a study and not a physician? Who's going to let go of that? And until then, I mean, you still need physicians. You might not need as many of them, but you're still going to need a physician to sort of be the final say.
So with that in mind, tell me, what does the far future hold for breast radiology?
I think we're going to continue to, new modalities are constantly emerging, and even the modalities we've had, we're making them better. I think, until we have a better predictor of who's going to risk stratify patients, we may get to the point where, genetics are such and sophisticated enough where they can say you won't get breast cancer. You don't need to screen. And you will get breast cancer. I mean, we're already doing that some with the genetic testing that we have just to identify the high risk patients. We don't currently have anything available that with confidence you could call somebody low risk and take them out of the screening pool. But I think the radiology will continue to evolve, but I think where we'll see the difference is in the biologics and genetic progression, where we can better risk stratify patients instead of just having a blanket recommendation for everyone.
I totally agree with that. We're going to have much better models for how we can make predictions based on, and AI is really good at big data, at taking the genome and 30,000 genes and being able to sift through all that data to say, here are the patterns that we think are going to be meaningful for it. So I completely agree with you. You're right, and you're smart. This is good. Okay. Now, what recommendations do you have to young breast radiologists that are just coming out into their field?
That's a good one. I would say, learn as much as you can, obviously, and get as much hands-on experience. And in all clinical medicine, you're good at what you do a lot of, so you just need reps. And it's very important to be trained by the best. I think, that's where I am today. It's not because there's anything special about me, but I had the opportunity to learn from some very smart people, who I'm just parroting what they taught me, essentially. We all are. You're a product of your training. And so I think it's very important to, be thoughtful about, within as much control as you have, where you're doing your training, because your clinical experience is going to shape the kind of physician that you're going to be ultimately. And that's, starting with medical school, where are you doing clinical rotations? What kind of pathology are you going to see? Same with residency programs. What kind of clinical setting are you in? What's the breadth of pathology you're going to see? Because
you want a referral center. You want to be able to see a lot of pathology.
See the weird stuff.
There's some weird stuff in Florida. One of the former presidents of Emerald Coast Medical Association, though actually the one who was responsible for bringing me onto the board initially, Rush Aiken, has a saying that all your attendings are watching over your shoulder.
Oh, absolutely.
And that's 100% it. And they said, they will catch you whenever you're doing things wrong, and they're still there to catch me on things.
I catch myself with quotable quotes from
you drop those all the time. Yeah. Anything's possible stuff. So now tell me about, what do you do for fun? What are your hobbies?
Well, I have 2 awesome kids who are
not
names? A hobby, but they're keep me/us very busy. Their names are Avery and Isla.
Which one's your favorite?
Oh, it depends on the day.
Okay, fair enough.
Our saying, just for the listeners, is we definitely never have a favorite. We routinely have a least favorite.
Routinely have a least
and
favorite.
And it truly changes by the minute.
It'll change quite often.
Changes with the wind. So, I mean, they're 7 and 9, so we're kind of in that busy phase of parenting where we get to do a lot of fun stuff with them. Go see Santa, go see, cartoon movies, and we're spending a lot of time doing family stuff, which is amazing. Yeah. I also grew up dancing at Tony's Dance Workshop here in town.
Shout out, Tony.
That's right. And so when I moved, I didn't continue dancing. I did a little, do classes here and there through college and medical school and residency. I really hadn't, it's just kind of hard to keep that up. There aren't as many sort of for fun adult classes. So I'd kind of let that hobby drop. And then when I moved back to Panama City, I had the opportunity to join a kind of an alumni class at Tony's. And so we've been doing that for the last 9 years. It's been really fun. There's a lot of nostalgia just being back in that studio specifically with a lot of the same teachers. It's been really awesome to have the girls.
Years, yeah.
This is her 50th recital, and I was in some of the early ones. So
I've seen pictures.
But that's been really fun, and it's a good group of women. It's kind of a nice outlet. It's movement.
And you're right. Having our girls go in and do that too.
Nice.
Yes,
like a dream come true to have them take class with Miss Tony.
Yeah. So speaking of those 2 girls, I did ask them for questions that we could ask you here, and unfortunately there weren't a lot that I could really ask that I'm willing to record. But I will say that Avery had asked me why you chose radiology.
Well,
I know we've covered that, but still, I want to make sure I respect her.
Yes, because it offers the opportunity to kind of meld all the things that are great about medicine with procedures and patient interaction and clinician, physician interaction, data analytics. So even though I have focused my practice now on only breast imaging, it's still very diverse. Every day looks different, and so that's why I chose it, and that's why I love it.
Yeah, you're not just automated on an assembly line. You really have to be thinking all the time. Yeah. And then Isla had asked, who's the funny one in the family?
Well, it's clearly you. You're the funny one.
It's clearly me. Okay, I'm just glad we got that down. Okay, I just want to make sure we record that.
She's going to give you a run for your money.
I'm not going to lie to you. All right. So I'm going to move on to some rapid fire questions here, okay?
I've heard you do that.
All right. Who's the smartest person in history? I'll have you know Mark Noon, who we both know, couldn't give me an answer.
No?
Nope. Didn't have one.
I can tell you a basic answer, which is, you could say Rankin, who is responsible for my specialty being in existence.
What a great answer. Yeah, exactly. And talk about, this is... radiology is indistinguishable from magic. You can look inside the body and you can see things. I think that oftentimes whenever we're doing echocardiograms, I'm watching the heart work live here right now, and I can tell all these different things. By the way, if you were to cut the heart open and look at it, there's plenty of blood and other things inside that are going to keep you from being able to see this. You're actually seeing how it functions in the valve. That is magic. It's absolutely black magic that we get to see.
And I still think that. Every now and then you'll catch a cool case and you're like, this is so cool. It's crazy that we can do this. Even now where it's very routine, but I think to think this is amazing that we have this. So whatever crazy person, thought it was a good idea to apply radiation to a human body and try to make a picture with it, turned out to have developed, what is cutting edge technology that really we could not live without in medicine.
A life-changing technology. I mean, the CT scanner goes burr in the emergency department now because, it's used ubiquitously. But I mean, I think these things are, sometimes when we take a step back about cath lab procedures, something like that, where if you take a second and take a breath and just realize what you're doing, it's, wow, I can't believe that we're elucidating the coronary arteries right here. Like, just the amount and breadth of knowledge that we've had to stand on the shoulders of giants in order to get to, that's pretty amazing. Yeah. And so, when you find a suspicious lesion on the ABIS or something along those lines, the layers of technology and knowledge that it had to come for you to say, this thing is going to kill this person if let go unchecked in 18 months. Yeah. I mean, that is really amazing.
The realization that, if we were born in a different time, that's not available.
So virtually anything but this very last nanosecond compared to the rest of the universal time. Yeah, exactly. So how about if we can live to 1,000, should we do it?
I know you ask that and I don't have
There's no wrong answers here.
I think there is some perspective and, knowing that your time is limited really, can catch you and be like, I need to be right here. I need to enjoy this because, the way we live our lives now, we don't know what tomorrow brings or if there will be a tomorrow for us or our loved ones. And so I think you would lose that if you had 1,000 years. I mean, what if you waste a year? Who cares? So I think while we all would love more time on this earth, nobody's ever ready to leave, I think you would not appreciate it as much if you could live for 1,000 years or longer.
Well, I may have to retire that question too, because I think you just nailed it. All right. I have no idea what you're going to say here. Too cold or too hot at night? Which one's better?
I'm too cold or
do you want to be too cold or too hot at night?
I'm going to regret saying this, but I'm too cold.
Oh, thank you. Oh, this is the best thing ever. Totally worth all of this.
You can solve cold, but it's very hard to solve hot.
I mean, too hot. Exactly.
Nobody can sleep when they're sweating.
I mean, you're sweating down in the Keys. That's terrible, right? You shouldn't sweat asleep. No. You can bundle up with covers.
But too cold within reason.
We're going to have to cut this part. What's one thing you would tell yourself if you could go right now as you started training?
I think I would say you will not believe what your life is going to look like in 20 years.
All right. What is one current medical treatment or therapy we are gonna shudder at in 15 years?
I think, at least as it relates to breast imaging, which is where my brain goes, prophylactic or risk-reducing mastectomy.
Yes.
Mastectomy in and of itself is a very, extreme procedure, and it saves a lot of women's lives.
Right.
But right now, when we identify patients who are high risk, and there's a very high likelihood they're going to get breast cancer, their options are to do, high risk screening where they're coming every 6 months and seeing a breast surgeon, getting a clinical breast examination. They're going to spend a lot of time with radiologists. They're going to get a lot of biopsies, and then they're always going to have that over their shoulder, like, what's this biopsy going to show?
Of course.
And so, another option for them is to have a mastectomy in advance of a breast cancer diagnosis you can never eliminate risk entirely, but to drastically minimize their risk lower than even the general population, because the less breast tissue that you have, the less breast cancer that can develop. And so that is very beneficial to a lot of patients, but I just have to hope that in the coming years we'll be better able to either detect cancer, much earlier, through proteins, blood tests, where we're not waiting for this mass to develop and potentially metastasize before we treat them. And in which case our treatment will be so early or even predictive that we don't have to put patients through that, because it's like two extremes and none of them are great options. They're both, they both come with their sacrifices. And so for patients in that position, I hope that, Dr. Moody, shout out to Dr. Moody.
Shout out, Alan Moody.
I hope she's doing fewer mastectomies in the future, especially on high-risk patients.
No, I think if we can get that marker that can get the instant that a cell turns cancerous, Like if we can get that and we can give a boost of immune therapy or something along those lines, that's how we really treat this and kind of stop the morbidity that goes along with that. But you're very right to think about the anxiety that goes along with having to get tested so often.
Right.
It's not fun waiting for results of tests.
Right. No, it's very anxiety provoking. And if nothing else, I mean, it's a hassle and it's expensive. You know, a lot of these patients that, you know, in this cohort are young working moms, you know, so like to be adding this to your mental load and also just, you know, physical time, it's a lot.
So what books are you reading right now?
I don't read as much this time of year, I found, because there's a lot going on. There's Christmas presents to buy and cookies to bake and all that stuff. So I have less free time, you know, for lots of good reasons. But I'm reading one book right now, which is called Keep Your Head Up by Dr. Tasha Faruqi.
Ah, Dr. Faruqi. Shout out Dr. Faruqi. Yes. What a moving story she has, right?
I mean, it's incredibly, I mean, her story is amazing. She's a great storyteller. I mean, I haven't finished the book, but I've already learned a lot. I mean, it's a great book, but I mean, I think her story, whether you have the opportunity to see her in person or you should also buy her book, is, I mean, it's incredible. And I think she has a lot to, she and her family have a lot to
Dr.
teach
Faruqi did not sponsor this
I just
portion
really
of the
like
segment.
her.
She was a keynote speaker at the Emerald Coast Medical Association CME events, the beach retreat. And she was just, it was not a dry eye in the house. What a wonderful story, and just
very
resilience
impactful.
and motherhood and pain and sorrow and resilience. Just an amazing story. So
yes, I'm happy to know her, and having known her story, it's like even more special to read her book and get the details. So that's what's on my nightstand right now.
Great recommendation. Okay, one last question. What do you want for Christmas? I need some hints here, okay? So
the list is getting longer.
This is getting a lot longer, especially after you did this.
I mean, if we record it, then you're going to be a little bit locked in.
Oh, that's right. Okay, well, tell me offline then, okay?
Fair.
So, Lindsey Weintritt Davis, where's the audience going to find you?
I am almost always findable at the Women's Imaging Center by Bay Radiology. Our office is on 23rd Street between Jinx and State Avenue.
And we'll put your contact information up so you don't have to recite the phone number now.
Yeah,
I would have
I do actually know it now.
But, good on you. Okay.
So that's where
Just look up Women's Imaging Center, Bay Radiology online, and you're going to come to you.
Our phone number is 747-4900 since you put me to the test.
Oh, there it is. Okay. Well, thanks to Curiosity Marketing. It'll be first on there whenever you pull that up.
It will. And thanks to them, you know, you can find us on social media and you know, we're working on upgrading our website too, just so that patients can find us lots of different ways.
Okay, well, thank you so much for being here today. Thank you so much for all the things that you do for our community, for many, many, many women and some men indeed. Thank you for being the love of my life. Thank you for being the mom to two awesome kids that I really like a lot.
You made me cry.
And thank you for helping us make medicine better together. Bye.